It's the giving season, and we are a nonprofit that provides such a wide variety of resources and services for the lean team that we are. And in 2020, the demand for our mental health services doubled, which means our team is trying to grow, and we are hoping that with your support, we can increase our mental health services along with our free health screening program. So your help will definitely go such a long way, whether or not you decide to give a lot, a little bit, or however much you can. Now, I'd like to introduce Dr. Neil Birnbaum of Pacific Rheumatology Associates. Dr. Birnbaum's clinical expertise has been recognized by his peers by his inclusion in every edition of the Best Doctors in America since 1994. And in addition to his many awards and honors, Dr. Birnbaum is also a committed educator. He is a longtime educator for the next generation of physicians, serving as director of the Division of Rheumatology at California Pacific Medical Center since 1983. And he also served as clinical professor of medicine at the University of California, San Francisco. He makes his expertise and knowledge accessible to community members as well. And he's a longtime friend of Community Health Resource Center. We're really grateful for his return each time that he is back. Welcome, Dr. Birnbaum. I will let you go ahead and share your screen.
All right. I think we're up and ready to roll. Thank you, Twin, for this nice introduction. It's always odd to do these programs by Zoom because I can't see your smiling faces out there. And I'm going to assume that you're all staying awake and fully attentive to my talk. And to tell you a little bit about you see down in the lower left corner, the Bone and Joint Initiative USA. The decade from 2000 to 2010 across the world was called the Decade of the Bone and Joint. And there was a Decade of the Bone and Joint group in the United States. And I was privileged to be the first American College of Rheumatology representative to the Decade of the Bone and Joint. At the end of the decade, it was decided that this public awareness campaign to show the prevalence and importance of recognizing and caring for people with various musculoskeletal problems was great enough that it should be an ongoing effort, and it became the Bone and Joint Initiative and still exists, as you can see. And one of the big things that they're trying to do is raise public awareness of the burden of rheumatic diseases, from anything from the car accidents to birth defects to arthritis. So this is a talk about arthritis. It's a very somewhat straightforward talk. It has a lot to do about self-management, and I'll be able to hopefully fill in some of the gaps and be able to talk to you about other aspects. I would ask when we get to questions that you limit them to kind of general questions. We try in these kind of talks not to talk about an individual's health problems. We're really not supposed to do that, but I'll be happy to answer questions on a general basis. So with that little bit of introduction, let me start. So this, I'm not quite sure who did these cartoons. I think this is what's saying is, all right, my nice dog wants to go out for a walk, and I'm having trouble. I've got pain, and how do we get to a point where I can comfortably have the knowledge to take Fido out for a walk and to have a better quality of life? So, what form of arthritis do you have? This is a common question. This is a large part about what rheumatologists do. So, the term arthritis simply means inflamed joint or joint disease. And there are more than 100 different types of arthritis. And half of a rheumatologist's job is to figure out what type the patient has. Now, fortunately for me, there's a handful of common types of arthritis, and then there's a bunch of rare things. So if I can sort through the half dozen or 10 different common types, I'm going to take care of 90+% of the patients who come in. And one of the basic things we try to do is differentiate between degenerative, mechanical wear and tear problems. That's what all of us get as we get older. There's not a person, I think, who escapes getting osteoarthritis someplace in their body, and it may be multiple places. So we call that osteoarthritis or degenerative arthritis. Those are interchangeable words, the arthritis of aging. And then we've got various forms of inflammatory arthritis. These are either autoimmune or other infectious diseases, of which the most common forms are rheumatoid arthritis, the arthritis of psoriasis, a common skin disease, a group of disorders called spondyloarthropathies that are inflammatory disease of the spine. There's gout, which is crystalline inflammatory arthritis. And then there's arthritis as part of various systemic autoimmune diseases like lupus. So here you see these drawings. This is a normal joint. And you see here you've got bone, and then the dark is the cartilage on the ends of the bone. And then you have the joint lining here, the synovium. So the cartilage is, if you take a chicken leg and you open it up at the knee, you got the drumstick and the thigh there, that smooth, shiny, pale yellow, gristly stuff is the cartilage. And generally it's smooth and shiny. Why? Because those are young chickens. As we get older, that cartilage can get worn thin and ragged, and now you end up over here on the right with osteoarthritis, which is just a wearing away of the cartilage. The body can't make new cartilage. It ends up making bone spurs or osteophytes. So that's one of the hallmarks of osteoarthritis. And then in rheumatoid arthritis, you have thickening of the joint lining here, the synovium, which then can crawl up onto the cartilage and eat away at the cartilage. And the synovium has inflammatory cells that release enzymes that degrade the cartilage. So we've got normal joint, we've got an autoimmune disease, an inflammatory process, and osteoarthritis, which is predominantly a wearing away of cartilage over time. So what about symptoms? They can vary from nothing. We can take x-rays of many people, and they really may not have much in the way of symptoms, or they'll come in complaining that the small joints at the end of their fingers are getting knobby and they don't like the appearance of it, but it doesn't give much trouble. They may complain of discomfort at the base of the thumb when they try to open a pickle jar or a mayonnaise jar. Maybe it's pain in your knees when you try to go up and down stairs. So a variety of different things. And then in the patients who have arthritis as part of a systemic illness, like, again, lupus, they may have joint pain, but also fevers and rashes and weight loss and a variety of other symptoms. And I think here they're trying to show that in addition to the pain and stiffness, these symptoms can get the better of you. They can cause sleep disturbance and significant fatigue, get you down in the dumps, and then there's a vicious cycle of pain and sleep and mood that all just starts to be a snowball rolling downhill. And how do we intervene in that process to make you feel better? So this is talking about take control. And I think part of this whole deck talks about a lot about patient self-management. How can you best on your own and working with your healthcare provider deal with having joint problems? There's a lot of things that the doctor can do, but there's a lot of things the patient has to do. And also today, everyone going online and they're reading and sometimes educating themselves, sometimes scaring themselves. And I often say that it used to be the patient who went to the doctor and viewed the doctor as the source of information. And now quite often we're the interpreter of information and trying to explain what you may have read on the internet. So you want to be the captain of your own ship. No one's going to look after you as well as you'll help look after yourself. And that team may include your primary care doctor. It may be a rheumatologist, it may be a physical therapist. It could be a athletic trainer, it could be family members, but it's how you can help feel like you're in charge rather than a victim of the process. So this talks about patient self-management. Kind of one of the things that's often very helpful if you want to go to the doctor and get information about your joint pain is try to take a careful history from yourself. When did the symptoms start? What seems to aggravate them? What makes them worse? What makes them feel better? What gives you some relief? Was there any kind of prior injury into a particular area? What have you done on your own to try to either diagnose the problem or manage the problem? Have you tried a number of over-the-counter preparations, whether they're Advil, Aleve, Tylenol kind of medicines, or have you tried various supplements and vitamins? So all things that when you go to the doctor, you can provide additional information. And anybody who's gone to doctor knows you fill out a lot of forms that ask these kinds of questions. Do you have related symptoms? Have you had weight loss, fevers, rashes, psoriasis, any number of things that might help the doctor make a diagnosis? What about your family members? If there's a history of a particular kind of arthritis in your family, very often there's an increased likelihood that you'll get the same kind of problem. Gout is a good example where gout very often runs in families. Knobby fingers, particularly in women, often run in families. Rheumatoid arthritis is more common in individuals who had a parent or a sibling or an aunt or uncle with rheumatoid arthritis. So what are some of the benefits of self-management? I think just feeling better and being able to be more active, being in that partnership with your healthcare provider, being able to do the things that you want to do, whether it's working in the yard or exercising or traveling or preparing Thanksgiving dinner, whatever it is, are all things that you could feel better with and help in your own self-management. So one is take control of the pain. It's oftentimes deciding who's going to be in control. Am I going to be in control of the pain, or the pain going to be in control of me? Now, that pain control may involve medication, and certainly even if you're taking over-the-counter medications long term, that's something you want to discuss with your family physician or your rheumatologist, but also what prescription medications are out there. We can talk a little bit more about it in the questioning period. There are certain medications that are just about pain relief, and there are others, particularly for rheumatoid and other inflammatory arthritis, that we call disease-modifying drugs that can not only control the current signs and symptoms of pain, swelling, stiffness, but also prevent future damage. If it's a disease like gout, there are medications such as allopurinol to lower the uric acid level and really prevent gout attacks. What about exercise? We really encourage patients to continue to exercise, but it may be not exactly the same exercise you did before. Runners become bikers, bikers become walkers or swimmers. People who did low impact exercise should really now switch to, if they did high impact exercise, should switch to low impact exercise. If you're going to go to the gym, think about increasing the repetitions, but keeping the weights or the tension on the machine light. If you're going to spend a lot of time at your desk, either at home or at work, have an ergonomic workstation so that you can be more comfortable there. And that may be a comfortable chair, having your computer keyboard at the right height. All those little simple things can make a big difference. And pursuing other kinds of exercise, maybe that you hadn't done before, such as yoga or Pilates or meditation, can be beneficial in helping to control pain. These are often non-medical things that individuals can do. And realize that you're a person, not from the neck up or the neck down, but you're a whole person. And the things that are going on in our life can affect how we feel physically. If you're not sleeping well, if there's been illness in the family or death in the family or a divorce, and that's affected your sleep and your mood, that really can make pain much more difficult to deal with. And we know that people can have exacerbations of their arthritis when they've come through other physical or emotional traumas. So we, in fact, sometimes use medications that were originally designed for sleep and mood as part of the management of chronic pain. Coping with fatigue, planning your day. That doesn't mean spend the whole day on the couch or lying in bed, but it may mean pacing yourself, deciding that you're going to clean the house over 2 days rather than 1 day, or asking for some additional help to get through some of the more burdensome chores if you're really having trouble accomplishing those on your own. And having that what now commonly called work-life balance. They're calling it here work-leisure balance, but in the workforce now it's called work-life balance. And I think there's a lot to that of accomplishing things you need to do either in a paid job or just in your home life versus enjoying life and how to do both even if you have arthritis. There are benefits of being active. I think we feel more mentally alert. And we also can help increase flexibility and balance. You can't really make a joint stronger, but you can make the muscles around the joint stronger. So that's important to do to maintain that kind of physical fitness. So what's the right fit? It's going to differ depending on your degree of disability or your age or other medical problems. If you've got bad heart or lung disease, you may be more limited. And here you show people doing chair exercises and either at home or watching television or going to a class. Walking is great exercise. And although it would be nice if everybody could walk 10,000 steps a day, for a lot of people, that's just a physical impossibility. They don't have the time. But think about 5,000 steps, and maybe you do it 2,500 steps twice a day and fit it in that way. And you can look either on a Fitbit or on your cell phone. It tells you exactly how many steps you've taken. Water exercise is terrific because it's low impact and you have got the buoyancy of the water to support you. But you have the resistance of walking or doing other exercises in the water. So a lot of different choices, but everybody can try to maintain some degree of cardiovascular fitness, joint range of motion, and muscle conditioning. I think it's often hard to stay motivated, and you do this on your own. And some people are very motivated, and a lot of us are not so motivated. And maybe you have a workout buddy or a walking buddy. For me, I belonged at one point to every gym within a 10-mile radius of where I lived, and I hardly went to any of them. We would try another one. We still never went. And finally, about 10 years ago, I got a trainer, and I show up, and I've been doing that for a long time, and I go twice a week, and I think it's really helped me maintain some degree of physical fitness. So you can have professional advice. Physical therapy is not something that people generally go to forever. It's something that you should go to primarily get information in how to exercise properly and to lay out a home program that you can follow once the therapy sessions ends. And whether that's a physical therapist or in my case, a trainer, those are people that you can look to, and you want to find the right person. I remember the first time I ever went to a trainer, it was some 20-year-old kid who had muscles. His arms were bigger than my thighs, and he was a bodybuilder. He wasn't really a trainer. My trainer now is a little younger than I am, and we get along well. And he understands that as you get a little older, you have some aches and pains and some limitations, but that doesn't mean you can't continue to do appropriate exercise. Healthy eating. Now, everybody asks, is there an arthritis diet? And the short answer is no. A good, healthy, well-balanced diet is appropriate whether you have arthritis or don't have arthritis. And a little meat or fish, chicken, and some vegetables and fruits, grains, and dairy products are all important in a healthy, well-balanced diet. The only thing we know is that if people are heavy and they've got bad hips, bad knees, a bad lower back, losing weight by a combination of diet and exercise can really help relieve arthritis symptoms. The other one is gout, where a low purine diet can reduce the amount of uric acid that's in the body and help reduce gout attacks, although diet is not nearly effective as taking a medication that prevents the formation of uric acid. Same question about supplements, and is there a special supplement? There are any number of them out there, but when put to an individual, a real study, they haven't held up terribly well. If you as an individual try a particular vitamin or mineral or supplement and feel that it makes you feel better, that's great. But that doesn't mean that I, as a physician, should recommend that to the next 10 people who come in the office, because I'm supposed to practice evidence-based medicine, which means there should be a good double-blind, placebo-controlled trial to support the use of a particular therapy. One of the things you have to remember is in any study that's ever done in arthritis, about 25% of people get better on the placebo, because arthritis has natural ups and downs. So it's always important to think about that when you read some of these trials. That's why there needs to be a placebo. Otherwise, you're having what I like to call an anecdotal testimonial. It worked for me. Well, that's great. And as long as it's safe, I think that's fine. And whether that's a real response or a placebo response, I think it's terrific. And people should follow something that they are comfortable with, they think benefits them, as long as it's safe and doesn't empty their wallet. So the do's of healthy eating with arthritis, you said it's a healthy, well-balanced diet. These are good things: fruits, vegetables, fish, grains, dairy products that help keep your bones strong. And then the don'ts, there's nothing here specifically about diet. These are all things with a lot of calories. And as I said before, if you're overweight and your poor old knee is lugging around 50 or 75 extra pounds of you, it's not going to like that. And there are patients who have gotten significant relief of their low back pain or knee pain by losing weight. That doesn't mean you have to get to be a waif. It's been shown that the greatest health benefits come from the first pounds that you lose. So let's say you lost 50 pounds. You get greater health benefits out from the first 25 pounds that you lose than from the second 25. That doesn't mean don't try to lose the second 25, but it also means don't beat yourself up if you don't get exactly to where you want to be. Supplements. I talked a little bit about this already. The evidence about easing knee pain is pretty marginal. Yet there are patients and physicians who have great faith in chondroitin sulfate or MSM or SAMe or others that are out there, but in large trials, they didn't really show very much. There may be other benefits, but also have to be careful about interactions with other medications. And periodically, there have been supplements that have ended up with significant side effects. I always tell the story. Many years ago, there was a natural amino acid supplement called L-tryptophan, and it was used for sleep and mood. It was very common, and a lot of people got sick. It was all basically made by one company in Japan and marketed by many, many different retailers. And they screwed up in how it was made, and a whole lot of people got sick, and some of them had significant damages. So my personal bias, I'll give you, not my doctor bias, my personal bias is if I didn't buy it in the produce department, I consider it a medication. So anything that comes in a pill form to me is a medication, and I don't take any medications that I'm not sure I need. I think I have a very healthy, well-balanced diet, and don't really think that I need a large number of supplements. But again, you're entitled to your own opinion. What about alternative therapies? This is a very controversial area, whether you call them alternative or complementary. I like complementary better because it implies that it's done in addition to well-documented FDA-approved type therapies, whether it's chiropractic adjustments or massage or acupuncture, acupressure. People will tout these. I think they tend to work better for soft tissue type problems, sprains and strains. I have not seen much improvement with true joint disease with significant arthritis, whether it's degenerative or inflammatory. It's this thing, staying vigilant. Don't necessarily do something because you read an ad in some throwaway newspaper or a well-meaning friend. Feel free to discuss these things with your primary care doctor, with your rheumatologist, and say, what do you think about this? What do you think about massage? What do you think about platelet-rich plasma? What's the latest on these things? And at least get the doctor's input. You may decide to try them anyways, but it's up to you. So this is saying, talk to people that are in your family that are affected. You're not the only one affected by the arthritis. Your family and others that you live with or interact with are also affected, and tell them, look, these are things I can do, and there may be a couple things I need some help with. I'm looking at this and wondering, since we had Thanksgiving last week, how many seniors continued to do the entire Thanksgiving dinner on their own, and have 20 family members over, all younger, who kind of arrive just as the food goes on the table, and somehow don't think about the fact that mom or grandma has gotten significantly older and would like to be more the supervisor and the co-worker rather than the sole participant in the very nice Thanksgiving dinner. So this is interacting with your healthcare provider. Get back to this, whether it's a nurse practitioner, physician's assistant, your internist or family practitioner, or a rheumatologist or orthopedist. Be prepared for your appointments. Really go in there with a list of your problems, your symptoms, your questions, things you want answered. I try to end a lot of the visits that I have with patients by saying, have I answered all your questions? Well, if you've got them written down in front of you, then you've got a better chance of remembering. Talk to the doctor about exercise and the difference between low impact exercise and high impact exercise, and what are good exercises and bad exercises. Really give that sense of what's making you better, what's making you worse. If you're coming back after starting a new medication, you want to be able to report Did you tolerate it, or did you have any side effects? And did it help you? And in arthritis, we're often asking about pain, function, swelling, those kinds of things. Doctor may ask you very specific questions. How would you rate your pain on a scale of 10? What's your overall improvement on a percentage basis since you started a particular treatment? They may give you a form to fill out. That's become very popular these days, to have what they call patient-reported outcomes in arthritis, where you fill out a form. We started doing those in our office recently for patients with RA, because insurance companies are starting to ask that when we put people on a new medication. Some of the ones for RA are very expensive. They want us to document in some kind of an objective fashion that, in fact, the patient has significantly improved. So this gives you a sense of how to make the most of your appointment. And again, be sure that you ask the questions you had and try to get the answers as the best the doctor can give you. And there may be times when the doctor has to say, I don't know. A lot of our appointments in the last year and a half have been in some way related to COVID. Will I, because I'm on a certain medication, does that increase my risk of getting COVID or having a bad outcome? What about the vaccine? Can I get vaccinated? Should I get vaccinated? Should I get the booster sooner or later? All those kinds of questions are very important. And it's been, as you all know, a very evolving area because the science keeps changing based upon the data that's available. I think the bottom line, though, is essentially everyone should get vaccinated and everyone should get the booster as soon as it is appropriate. So that would just throw that bit of information in. So let me stop here and see if you have any says concerns or regards to your arthritis. This is where it would be nice to have you all in a live audience.
We have a person who's raised their hand. Joel, go ahead and let us know what's on your mind.
Okay, my question is, with osteoarthritis, are there ways of slowing the progression of the disease over time?
Yeah, it's as all of us get older, myself included, we all get osteoarthritis somewhere. And unfortunately, right now, there is no well-documented, what we would call disease-modifying drug. In rheumatoid and other inflammatory forms of arthritis, we've had a multitude of new therapies over the last 20 years, the medications like Enbrel and Humira and Remicade that everybody gets bombarded with ads for. Osteoarthritis, that does not yet exist. We're really talking about pain relief. I think the things that I could say about slowing progression is one would have been choose your parents carefully. Of course, we can't do that. That if they had bad arthritis, that increases your risk of getting osteoarthritis to a more significant degree. Keeping weight down, and so that the knees and the hips and the lower spine don't have to carry as big a load. Then there's a lot of post-traumatic osteoarthritis. If people were football players and had knee injuries and meniscus surgeries, they're certainly at higher risk to get post-traumatic osteoarthritis later in life. But that's about what's out there. I wish there was something else because I'd be taking it if there were.
Next up is Ronald. He asks, does chondroitin glucosamine work?
So I alluded to that earlier, that there was the largest study ever done was a National Institutes of Health study on glucosamine and without chondroitin sulfate. And it was a negative trial. It was not shown to be beneficial. Having said that, there are individual patients and a few doctors who are true believers in glucosamine and or chondroitin sulfate. So if you want to, you can try it. I probably would give it a 3-month trial. But again, if you want hard data, it's lacking.
Next, we have Valerie.
I was wondering if the rate of cartilage loss in your knee, for example, is steady over your lifespan, or does it increase or diminish? The rate change as you get older?
Okay, good question. So it varies a great deal. There are patients who will never have any trouble. And there are other people who will start somewhere 40, 50, 60, 70, whatever it is, and they'll start to have some very modest symptoms, and maybe it never becomes very severe. And in other people, they kind of fall off a cliff. They go along and suddenly the rate of deterioration increases. I think what happens sometimes in that situation is the cartilage gets ground up, a little bone fragments, cartilage fragment, and it acts like gravel in the joint, and it chews up the remaining cartilage at a faster rate. But it's extremely variable. Some patients will go years and years and never need to do anything else. Someone else in the space of 6 months or a year is having so much trouble that they're ready for a knee replacement.
Thank you so much for your question, Valerie.
Thank you very much.
Next, we have Anita.
Oh, hello.
Right.
Oh, hi. I have complex regional pain syndrome, and I wanted to know how do I know whether my arthritis is triggered by complex regional pain syndrome or just age-related issues? And the treatment, I suppose, should be different.
Yeah, without getting into the details of your individual case, complex regional pain syndrome and arthritis are generally considered two different problems.
I hope that answers your question a little bit. Anita, if you have anything else, go ahead and let us know. Otherwise, we'll move on to other questions in the Q&A.
Okay, thank you.
Thank you so much, Anita.
Between arthritis and gout. So gout is a form of arthritis. So again, anything that involves the joints is arthritis, and gouty arthritis is a crystalline arthritis. It's very common, particularly in San Francisco, where we have a lot of people of Asian ancestry. There's a lot of gout in Filipinos, Chinese, Samoans, etc. And it's caused by too much uric acid. Uric acid is a protein breakdown product. Certain proteins called purines are converted in the body to uric acid, and you get gout. You got too much uric acid, either by taking in a high purine diet or making a lot of purines or not excreting enough uric acid through the kidney. So if you get a very high blood level of uric acid, it can spill over and crystallize in the joints and causes a very acute painful arthritis that classically starts in the bunion joint of the big toe, where it's called podagra. The best description of gout ever written was written almost 300 years ago, and the author said, place your toe in a vice and twist it as tightly as you can, and you'll have a sense of rheumatism, whatever rheumatism is. But then give the instrument one more turn and you'll get a sense of gout. And it's a very painful problem. That he goes on to talk about how even having the sheet on the affected toe is very painful. Or somebody walking past the bed causes a lot of discomfort. So but fortunately today, with medications like allopurinol, it's an entirely controllable problem, and no one should be having ongoing gout attacks.
Someone says their parent had really severe arthritis, and this person is starting to see the signs of it herself. She wonders about the steps she can take to stave off the symptoms.
Well, I think that this is a good time to see either their family doctor, or if need be a rheumatologist, to get a sense of what kind of arthritis they have. And it would be very important to come to that visit with as much information about your parents' problems as you can have. And did they have osteoarthritis? Did they have rheumatoid arthritis? Did they have gout? Because those things tend to run in families. That doesn't mean that's the only kind of arthritis you could have, but certainly it would be helpful information and as to whether or not there's something that you could do. If it's early rheumatoid arthritis, yes, there are now any number of very effective medications that could be used to try to prevent the progression of that kind of a problem. If it's osteoarthritis, if mom had knobby fingers out here at the ends, the little joints, and that's what you're getting now in your 50s or 60s, that's the likelihood is that's what you're going to have is osteoarthritis. And the good news is that it's probably not going to ever be a terrible problem. The bad news is I can't do very much about it.
Thank you. The next question submitted through registration, and you're going to have to help me with the acronym here, Dr. Birnbaum. What are the best treatment options for UCTD?
Okay, so UCTD means undifferentiated connective tissue disease.
Thank you.
So there's a spectrum of diseases that include things like rheumatoid arthritis, lupus, polymyositis, scleroderma, Sjogren's syndrome. These all are diseases characterized by the presence of autoantibodies within the body. And sometimes you kind of get the sense the patient's got something, but you're not quite sure exactly what. So we call that an undifferentiated connective tissue disease. And that's the kind of thing where you would be wanting to sit down with a rheumatologist and get a sense of, is that the right diagnosis? And if so, how severe are the manifestations? And treatment could be as simple as a drug called Plaquenil, hydroxychloroquine, which some people will remember was touted by our former president a couple of years ago as being effective for COVID. It didn't work for COVID, but it's going to be pretty effective in problems that like this. Sometimes it's low dose steroids, and other times it requires more extensive immunosuppressant therapy. So it's one where you really need individualized care.
Thank you. Ronald, if you're still with us and you have a question, feel free to let us know.
Sure. Can you hear me?
Yes, we can.
Oh, excellent. My question is this. If a person has multiple areas, ankles, knees, low back, shoulders, neck, with osteoarthritis, is ibuprofen, is that effective?
It can be. So again, the management of osteoarthritis is the management of pain, and whether that's pain in one joint or many joints, you got to remember that the pain medicine isn't really working in the joints, working in your brain, where the pain receptors are. If you have a painful joint, there's a nerve ending within that joint. It's sending a message to a sensory nerve that goes to your spinal cord, goes up your spinal cord and into your brain to the sensory strip in the brain where it registers. And that's where pain medicines work. So it could be effective. And for many, many patients today, that's what they end up taking. The number of people today who take prescription non-steroidal anti-inflammatories is appreciably less because Advil and Aleve are available over the counter. Remember, Tylenol, acetaminophen, is only a pain reliever. It's not an anti-inflammatory. And for osteoarthritis, it may be enough. And the advantage of Tylenol over non-steroidals is safety. So the Tylenol generally doesn't cause stomach bleeding or ulcers, and it's less likely to cause any problem with the kidney or with elevating blood pressure. Non-steroidal anti-inflammatories, Advil or Aleve, may be a little more effective, but they carry a greater risk.
Oh, thank you.
Thank you for your question, Ronald. We have over 20 questions left here on our Q&A and about 40 minutes left. So I think that we're making good time, Dr. Birnbaum. Our next question is what would be the best exercises and foods for arthritis? And I know this might require more nuanced explanation. And then before you get into that, Dr. Birnbaum, we also have a lecture by one of our registered dietitians here at Community Health Resource Center. The presentation is recorded and uploaded onto our community presentation archives on chrcsf.org. And we have our dietitian, Elena Zidaru, who goes into detail about the kinds of diets that could help to manage your inflammation and joint pain. But there is no cure-all. There are things that you can do to help make daily life feel easier.
So as I mentioned before, there is no special arthritis diet. It's a healthy, well-balanced diet. There are shelves of books with their various arthritis diets, the no nightshade, the antioxidant diets, whatever you want to read. And if you read them, they generally tend to contradict each other. But there's no well-documented osteoarthritis diet or rheumatoid arthritis diet. It should be a good, healthy, well-balanced diet. And if you're overweight, it should be a lower calorie diet so you can take a load off your poor old joints. And again, the one exception being a low purine diet, which can be used for gout. As far as what was the other part? Exercise. Yeah. So exercise, again, to repeat what I said in the talk, we want people to stay active. We want to put joints through a range of motion. I want to maintain muscle tone as much as possible. But in very basic principles are low impact versus high impact. So we prefer something that's walking, swimming, biking versus running, basketball, tennis. And if you're going to work out with weights, keep the weights light and increase the repetitions. And in that way, you avoid getting hurt.
Is there a test to know which kind of arthritis you have?
Yes. So making a diagnosis, what we do every day as a rheumatologist, involves taking a careful history. So for instance, inflammatory arthritis, rheumatoid arthritis is characterized by nighttime pain, morning stiffness, better with activity. And osteoarthritis, generally people don't feel too bad in the morning, but the more they get up and weight bear on their damaged joints, they feel worse later in the day. So that can help. What's the joint distribution? If a certain kind of arthritis go to different parts of the body. Little joints out here are usually osteoarthritis. This row of knuckles and this row of knuckles is usually rheumatoid arthritis. So we want to get a sense of that. So history, physical exam. There are laboratory studies. In osteoarthritis, because it's not an autoimmune problem, the laboratory studies are generally normal. If it's inflammatory arthritis, there are markers. There's rheumatoid factor and CCP antibody that are positive in most patients with rheumatoid arthritis. There are measures of inflammation called SED rate, or ESR, and CRP, C-reactive protein, that often will be elevated in inflammatory arthritis, but tend to be normal in osteoarthritis. Now, they're non-specific measures of inflammation. They'll also go up if there's any other kind of inflammatory condition. And then x-rays may play a role. We know that in osteoarthritis, there are development of little bone spurs or osteophytes. And in rheumatoid arthritis, we're looking for erosions, little places where the inflamed synovium has chewed away at the cartilage. So that combination of history, physical exam, laboratory testing, and x-ray will hopefully lead us to a proper diagnosis.
Thank you. Next question, is Gaucher disease a form of arthritis?
Gaucher's, so Gaucher's disease is so rare that I've never seen a case. So it can involve, I think, more bones than joints, but I'm not an expert in Gaucher, so I'm going to pass on that.
All right. Is there any way to lessen risk of arthritis associated with growing old?
So that's osteoarthritis or degenerative arthritis or aging arthritis. And as I've said before, the best would have been to pick your parents carefully, because if your parents had osteoarthritis, there's a fair chance that you will. or higher chance. Otherwise, I would think about if you do sports that have a lot of high impact injury, like football players, understand that you pay a price a lot of times. And I've taken care of a few professional football players. They're pretty beat up. Now, every one of them would do it again for the competitiveness and the joy that they had from playing football, but there's a price to pay.
Next question. How might one decide when is the right time for knee surgery versus management for knee pain? An
Sure.
example of this person is that they're over 80 but are in good health.
Yeah. So that's a common discussion. And actually, a rheumatologist is not a bad person to talk to as kind of a second opinion, because we don't have a vested interest. I don't do the surgery. It's based upon the degree of pain and the degree of disability. How much is this problem interfering with somebody's life? I always tell the story that I can see two patients who both complain of knee pain, and I put their x-rays up and they both look terrible. And they both tell me they can walk about 8 blocks. But the one patient says, "Oh, gosh darn, I can only walk 8 blocks. I'm so frustrated." Patient's ready for a knee replacement. The other patient comes in and says, "I just walked 8 blocks. Not ready for a knee replacement." So it's everybody's different. One person's 8 on a scale of 10 for pain is probably somebody else's 4. It all depends how active people are, what do they want to do. And then there's a certain point when you start talking about what we call comorbid conditions. How is their overall health? If someone has severe heart disease, they may not be a candidate for a knee replacement, but you can really do knee replacements in people today. Age is not the contraindication. It's health. And I give the example of my mother, who at age 85 very suddenly had her knee fall apart and was really having trouble getting around. And she was just adamant that she wasn't going to have surgery. And she went to several different people, including her son, the rheumatologist. And finally, everybody said, "Mrs. Birnbaum, you're really going to have knee replacement." And she, "Well, I'm not going to." But then a month or two later, she said, "I'm really not going to spend the rest of my life sitting in a chair." So she had her knee replaced at age 85. She had a completely uneventful course. And I'm happy to report she's now 98 years old and she walks just fine. And her knee has held up extremely well over the last 13 years.
Thank you for sharing. Our next question asks about the habits of cracking your fingers. Do they increase the likelihood of arthritis?
So despite what our parents and grandparents always told us, that there is no evidence that cracking your knuckles increases the risk of arthritis. The cracking comes because there's nitrogen gas bubbles in the joint, and that's supposedly where the cracking comes from.
Thank you for clearing that up. I know that for a long time I also believed that because of my parents.
Right, and mine too, I'm sure.
This next asker wants to know if you can talk about arthritis triggered by aromatase inhibitors.
So aromatase inhibitors, for everybody's background, are medications that have become very popular last few years to treat breast and other forms of cancer, and they can be very effective in reducing the rate of cancer spread and increasing survival. They can have side effects, and one of the side effects can be quite severe joint pain, and if it's mild to moderate, people can get by with pain medicine, non-steroidal anti-inflammatories. Occasionally, if it's severe, the medication has to be stopped and maybe switched to something else. But it's a fairly significant issue when it occurs. It can be quite debilitating.
To add to that, last month, we hosted a talk by Dr. Milana Dolezal. She provided a talk called Managing the Side Effects of Tamoxifen and Aromatase Inhibitors. This sounds like a possibly useful resource for you, whoever asks this question. It's going to be on chrcsf.org/videos. Feel free to
Great.
explore.
Yeah, see, they get the numerator, which is all the patients. We get the denominator, or no, the denominator, which is the other way around. It. We get the numerator, they get the denominator. We get the few patients who have trouble, they get everybody. So they have a better sense of how frequently it occurs.
Thank you. Our next question asks for tips on how to manage our osteoarthritis pain in the knees.
So a couple things. One, I'll say it again, knees don't like extra pounds. So if you can get your weight down, and I know it's hard, if it's harder to exercise, it just makes it that much harder to lose weight. But if you follow whatever diet it works for you, whether it's Weight Watchers, or I like the no white stuff diet, the no potatoes and rice and starch and pastries and things, the no white stuff, anything that helps you get pounds off will help. You can do exercises. And we talk now about isometric quadriceps same thing exercises. Isometric means when you tighten the quadriceps muscle, but you don't put the knee through a range of motion. And I'm sure if you go online, there's a YouTube on quadriceps strengthening exercises. If you can avoid those activities that tend to aggravate it. So in general, going down hills or down steps is much harder on your knee than going up. So if you want to climb the steps for exercise, but take the elevator down, it takes a load off your knees. And then sometimes intra-articular steroid injections, you put a little cortisone in, and that can be very effective for osteoarthritis. It can be done a couple times a year, and often will stave off having joint replacement therapy for a while. There are other things you can inject into joints. There are what so-called viscosupplementation agents, kind of like WD-40 for your joint, that have names like Synvisc and Halgan and Supars that are made up of collagen building blocks. I quit doing them. I just didn't have much success, didn't have any success. There are physicians who seem to believe that they're of benefit. They're FDA approved. There's platelet-rich plasma, which has become quite popular lately, but it's not covered by insurance, and I don't think it will be now. There was just a paper published last week that showed no benefit to platelet-rich plasma for osteoarthritis of the knee. And if all else fails, knee replacements are very effective. There are several 100,000 a year done in the United States. And I would say 95% of people who have the surgery done are very happy that they had it done. I forgot to talk about bracing. So there are braces that usually are used. It's more common in osteoarthritis to wear out the inside part of the knee, the medial compartment it's called. And there's something called an unloader brace that shifts the weight from the inside compartment to the outside compartment of the knee. They're out there. In my experience, very few people can wear them. They're lightweight, but they're bulky and they're awkward. And, other than a couple of masters tennis players who wanted to play a little longer before they got their knees done and would wear them to play tennis, I haven't seen anybody really be able to tolerate them very well.
And our next question, how can joint and systemic inflammation be reduced?
Well, again, there's no well-documented anti-inflammatory diet. You can try them. There's a lot of them out there, but if you ask, are they well-documented to be beneficial? No. That doesn't mean they won't work for you, and whether that's a real effect or a placebo effect is fine, but it's not well-documented. There are certainly, when people take non-steroidal anti-inflammatories, drugs like Advil, Aleve, Motrin, Celebrex, those play a role not only in pain relief, but in reduction of inflammation. There are steroids, cortisone, prednisone, that are anti-inflammatory. And the same goes for intra-articular injection of steroids. So whether it's systemic, oral steroids, or intra-articular. And then if people really have an autoimmune inflammatory arthritis, if they have rheumatoid arthritis, then we have this explosion of very effective disease-modifying therapies that have come on the market in the last 20 years that really turn the disease off. And it's very rare today to have a patient with osteoarthritis or psoriatic arthritis that we can't come up with a very effective treatment regimen for.
On that note, somebody also asks about cortisol. After a couple of treatments of cortisone shots, it loses its effectiveness. What's going on there?
Well, the cortisone needs a little something to work on. So if you go from having some cartilage damage to more advanced cartilage damage, then eventually the cortisone just isn't going to work. And that's when people say, you know, going to get my knee done.
Got it. Thank you. Our next question is asks about any natural remedies out there.
So there are millions of purported natural remedies, but well documented, no. And that's why I like to use the term complementary medicine. If you want to try that, and whether that's vitamins or minerals or supplements or acupressure, whatever you want to try, you can do that, but don't do it to the exclusion of well-accepted FDA-approved therapy.
Next is an example. If I don't want to drink regular milk with 100% fat, can I drink milk with 0% to help with bone strength?
Yes. Yeah, to the best of my knowledge, this is a different area because we're talking about osteoporosis prevention. So osteoporosis is thinning out of bones. Osteoarthritis is the wearing out of cartilage. But as far as I know, there is as much calcium in fat-free milk as there is in fatted milk. If you don't want to drink milk, you can take a couple of calcium carbonate tablets, and you can buy the 500 or 600 milligram calcium carbonate with about 400 international units of vitamin D each, and you take 2 or 3 of those a day, and then you don't have to drink any milk.
The next question is by James. Are there ill side effects from extended use of prednisone?
Yes. So the potential for side effects from prednisone is very much a function of how much and how long. People can take short courses of steroids, even at high dose, usually not have much problem with it, maybe a little difficulty sleeping or irritability. And oftentimes people can take low doses of prednisone for protracted periods of time and not have trouble. The list of potential side effects from steroids is very long. It ranges from weight gain, easy bruising, soft bones. It can aggravate diabetes, high cholesterol, hypertension, cataracts, glaucoma. It's a pretty long list, and we know what all those side effects are. There are times when we simply have to use large doses of steroids of prednisone to keep somebody alive. You have a patient with severe lupus, until other medications get a chance to kick in, that's the most effective therapy that we have. In rheumatoid arthritis, we really try to limit the prednisone to 5 milligrams a day. And I have a lot of patients who will even take it 5 milligrams a day as needed. If they know that they do fine most of the week, but they have a dance class on Saturday they want to take, they'll take it on Saturday. Go do the dance class. And that keeps the total amount of cortisone even less. 5 milligrams a day or less would be small time steroids and usually well tolerated.
This next question is sort of 2-part. Do young people who exercise a lot, such as their athletes, are their chances of developing arthritis reduced? And if they wanted to prevent arthritis or stave off because they have a family history, what are the steps that they can take?
Some people are made to exercise. They can do whatever they want and they never have an injury. And other people, every time they go out to do something, to go running, they twist their ankle, something happens that's bad. Those people probably shouldn't be high impact exercising. But there was a study years ago done at Stanford of long-term runners. And they tended not to have more arthritis, but it was probably a process of self-selection, where the people who got hurt, they quit running eventually. And the people who were built to run, they kept on going. But I think in general, again, lower impact exercise is going to be better for people than high impact exercise. And lifting a light weight more times is easier on your joints than lifting a very heavy weight a few times. People should be meticulous about stretching, particularly as we get older. If you look at the professional athletes who've played into their 40s, Tom Brady kind of person, they are meticulous about stretching and nutrition. But they, because a lot of times what does in the older athlete is a muscle pull or problems with a tendon or a ligament. And as when we're younger, our tendons are more like rubber bands. And when we're older, they're more like a leather strap. And you really have to work to maintain the flexibility. So stretching is really important.
Next question, would you recommend ice or heat for pain?
Depends. So it depends on what you like. If you think about professional athletes, you'll often see them in the hot whirlpool before the game, loosening up. The guy pitches 7 innings, and now you see him, he's on the bench, and he's got an ice pack on his shoulder to keep down swelling after exercise. So that's probably the most common way that heat and ice are used, but it varies a great deal from individual to individual. Some people like what they call a contrast bath between hot and cold. I've never been quite sure what the purpose of that was. So everybody can do what they like, what seems to work best for them.
Next question, does having fluid around your kneecap drained help with pain?
So the fluid is produced. We have normally a certain amount of synovial fluid. It's produced by the synovium, that lining layer of the joint, and it's there to provide nutrition and lubrication to the cartilage. If the joint is injured in some way, then oftentimes there's excessive fluid produced. The body's trying to do something to help itself. It can't make new cartilage, so it makes extra fluid. And that fluid may have in it certain inflammatory cells. So removing that fluid can provide some immediate pain relief, because if the knee is very swollen, the nerve endings are in the capsule of the joint. And if they're being stretched, that can cause pain, and relieving that stretching can reduce the pain. Now, if you simply remove the fluid and don't put some cortisone in, very, very often the fluid recurs almost immediately. So the benefit may be very short-lived. Whereas if we put some cortisone in, then we may provide very long-term relief of the pain and swelling. But we have to be careful and to use intra-articular storage judiciously. Judiciously for most of us is probably twice a year into any one particular joint. You could do a different joint, but we try not to do the same joint more than a couple times a year. Sometimes if someone's going away on a trip or they want to dance at their child's wedding, we'll stick an extra one in.
This next question also has to do with fluids. Does staying well hydrated promote the lubrication in your joints, such as drinking plain water?
Yeah, not that anybody knows about. No, it's a long way from taking that water into your stomach and in the production of joint fluid. No. I mean, it's a good idea to stay well hydrated, but I don't think it has to do with joint fluid.
Our next participant asks, is it possible to have both osteo and rheumatoid?
Absolutely. And we see that a lot today. I think we said this earlier, where if I saw somebody at age 40, which is a typical age of onset of rheumatoid arthritis, and we recognize that and treat them, nowadays they may get to age 60 and have no evidence of active rheumatoid arthritis as long as they've stayed on appropriate therapy. But now they get old enough to start wearing out joints and getting the typical osteoarthritis that all of us get. So yes, it's not at all uncommon to have the coexistence of rheumatoid and osteoarthritis.
This next question asks, is most treatment now really just about treating symptoms? At what points can you consider remission for arthritis? Is it possible?
So if it's osteoarthritis, it's still about treating symptoms. We don't really have something that regrows cartilage or preserves cartilage. If it's inflammatory arthritis, if it's rheumatoid arthritis, psoriatic arthritis, spondylitis, that's a whole different ballgame. We have any number of what are called DMARDs, disease-modifying anti-rheumatic drugs, and that means they've been shown in a well-done placebo-controlled double-blind trial to have slowed or halted the rate of damage to joints as measured by serial x-rays. So our goal today is to take people with inflammatory disease and put them into remission or low disease activity using medication. Now for us, remission means usually remission on medication if these are autoimmune inflammatory diseases, because there's the autoimmune problem is still there. It has to be controlled. There aren't many people that we can treat them and stop the therapy because the disease comes back.
This question goes back to medication. One of our attendees wants to know if 5 milligrams of methylprednisone is a better choice for long-term pain relief versus ibuprofen.
Very different. If this is osteoarthritis, the answer is no. We tend not to use prednisone for osteoarthritis, so we tend to limit it to inflammatory disease. Non-steroidal anti-inflammatories are analgesics and they're anti-inflammatory. Prednisone is a steroid. It's anti-inflammatory. It's not analgesic.
And would it be possible to have rheumatoid arthritis and have it show up in a blood test, but not show any symptoms?
Yes. So there are patients who carry around a rheumatoid factor, and this has been looked at. They've looked at banked blood that the people provided samples for something. And a certain number of people will have a positive rheumatoid factor in their blood. Some of them will never have a problem. And some of them may eventually have a problem, but it could be years and years before they have any trouble. So a positive rheumatoid factor without any joint complaints is not rheumatoid arthritis. It's a lab test in search of significance.
Daisy asked about her son's injured ACL in high school. Does that mean that his chances of developing arthritis has increased, or that he will develop arthritis earlier?
Well, I think it increases the chance. It doesn't mean he will, but certainly we know that people who have had a significant injury, whether it's an ACL, a torn meniscus, whatever, do have a greater chance of getting osteoarthritis later in life. Years ago, they used to remove the torn meniscus completely, and they eventually figured out, because they said, if you don't remove it, you might get arthritis later. And then they eventually came around and saying, if you do remove it, you will get arthritis later. So that's why when there's a meniscus repair, they try to preserve as much of the meniscus as possible. Same with these major ligament repairs. You try to get the joint as tight as you can with the reconstruction, but there is some greater risk of a post-traumatic arthritis later in life.
Possibly related to the fluids on the knee, what is your advice for an arthritis cyst on a finger joint Is it better to remove it or leave it alone?
For a cyst, was that the question?
Yeah, arthritic cysts.
Yeah, so there are cysts in osteoarthritis. They're usually out at the little joints at the end. It's called a mucinous inclusion cyst. And sometimes they'll even pop open and stuff comes out that looks like jelly, current jelly. A lot of times they'll drain on their own, or we can put a little needle in there and drain it and inject a few drops of cortisone, and oftentimes it doesn't come back. It can be operated on, but it doesn't have to be operated on. I have one here, and it's actually gotten smaller, and I haven't done anything about it. So.
Is it a myth that consistent use of cortisone diminishes the cartilage?
No, I think there's evidence that says if you inject the same joint every month, that can be degradative to the cartilage, damaging to the cartilage rather than protective. And that's why we tend to not inject joints more than a couple times a year.
Have you seen penicillin being used to treat arthritis?
Penicillin? No, because it's not a bacterial infection. I mean, if you had staphylococcal arthritis, you could have it in a bacterial infection of a joint, what's so-called septic arthritis. Yeah, you might use a penicillin in that situation. Now, there's an old medicine that's not used anymore called penicillamine that was used when I first started out to treat arthritis and scleroderma, but we haven't used that in a long time.
If inflammatory issue is no longer there for SLE, then is it necessary to continue taking hydroxychloroquine?
Okay, so most lupologists, people who are rheumatologists who subspecialize in lupus, would tell you they never take the patient off hydroxychloroquine, or Plaquenil is the trade name. And the reason for that is that it's an extremely safe medicine. So when you look at the risk-benefit analysis, the potential benefit of staying on far outweighs the potential risk. And the long-term potential risk has been to the eye, to the macula. And as long as the dose of Plaquenil is adjusted for the weight of the patient, no more than 5 milligrams per kilogram of body weight. And as long as the patient goes yearly to have their eye exam done, the risk of retinal problems is extremely low, and probably never occurs in less than 5 or 10 years on therapy.
This asker would like you to revisit the topic of methylprednisone. They want to know if it's okay to take every day for long-term pain management, or is it just as needed?
Well, it can be either way. If you're doing either methylprednisolone, which is Medrol, or prednisone, if it's very low dose, if needed, it can be taken daily. But there are other people who take it only on an as-needed basis. If you're taking higher doses of prednisone, if you're taking 10 milligrams a day or more, you can't just go on and off like that. You have to taper off. The reason is that our bodies make cortisone. It's made in the adrenal gland. The gland that sits on top of the kidney. And when you're taking large amounts of cortisone by mouth, the body senses that, and it turns off the production of prednisone. And therefore, you need to taper from these higher doses of prednisone to allow the adrenal gland to wake up. The adrenal gland doesn't die, it just hibernates. So you have to allow it to wake up. If you're in the 5 milligram a day or less range of prednisone, which is 4 milligrams of methylprednisolone, which is the equivalent amount, then the adrenal gland should not be sleeping, and you can go on and off on an as-needed basis.
That was our final question, and I think that there's really only one more, but it may be a former patient of yours. Ev in the audience would like to know if you're still practicing.
Yes, I have no intention. Thank you for asking. No, I'm still very active. I'm the senior managing partner of Pacific Rheumatology Associates, and I'm fortunate to have 3 wonderful colleagues, Doctors Ishita Agarwal, Molly Magnano, and Pedro Ruiz. And we have been in Suite 112 at 2100 Webster, down this hall from your office, and been there since the building opened. And yes, I'm still practicing, still enjoying it.
We're getting a lot of love for you in the chat. Dr. Birnbaum, would you like to leave our participants with any last words before we sign off for the night?
Sure. Number one, thank you all for attending and all these great questions. We managed to get through an hour and a half without any problem. We took up all the time, so that's good. I think that, again, be proactive. Be an educated patient. The best thing you can do is look after yourself. No one's going to look after you as well as you look after yourself. That doesn't mean don't go to the doctor, but that means work with your doctor, whether it's your primary care or rheumatologist, orthopedist, whoever you're seeing. We're in an era today of patient-centric medicine. That's why we do these kind of programs. And I think that it's the way medicine ought to be. We're long past the era of the patient coming in and saying, "Doc, just tell me what to do." That doesn't happen anymore. But we want to be able to answer your questions, and in that way, you'll have the best outcome.
Thank you so much for your time and your thoughtfulness towards everyone's questions. I think this has been one of our most active Q&A discussions we've had since we started doing webinars. So I am really, really appreciative that you decided to join us here today, Dr. Birnbaum.
Thank you. Thanks to all of you for attending.
Thank you so much. And we'll see you in 2022. That's when our next lecture is.
Bye-bye.